Welcome, and thank you for standing by. At this time, all participants are in a listen-only mode. After today's presentation, we will conduct a question-and-answer session. To ask a question, please press *1. And today's conference is being recorded. If you have any objections, you may disconnect at this time. I'll now turn the meeting over to Patricia Breen. Ma'am, you may begin.
Thank you very much for attending HRSA's third Risk Management Audio Conference of 2012, entitled Right on Time, Safe and Timely Delivery of Neonates. My name is Patricia Breen, and I'm with the Office of Quality of Data in the Bureau of Primary Healthcare at HRSA. Today's presentation is the 8th in a series of risk management audio conferences designed to assist you in developing an effective, robust clinical risk management program at your health center or free clinic. We at BIPIC are committed to supporting your efforts to deliver quality health care to patients, and to that end have partnered with APT Associates and ECRI Institute to provide this information. I will now turn over the program to Mr. Paul Anderson.
Thanks, Patty. On slide 2, you'll see some more information about ECRI Institute. We're an independent, nonprofit applied research institute, and over the past 4 decades, we've helped thousands of healthcare organizations across the nation develop patient safety, healthcare quality, and risk management programs to improve patient care. With your audio conference registration confirmation, you received an email link to the slide handouts, and we hope you've had the opportunity to print or download the slides. Throughout the audio conference, we'll refer to slide or page numbers in the handout so you can follow along. This is a continuation of our brown bag lunch audio conferences, all of which are archived on the website if you missed them live. We will have a question and answer session at the conclusion of today's program. However, keep in mind that this audio conference is not the appropriate place to discuss detailed, case-specific aspects of unresolved claims or litigation. Likewise, risk management information provided in this audio conference is not to be considered legal advice. And as with any information provided by ECRI Institute, it's intended as guidance to be used consistent with the internal needs of your organization. This information is not to be viewed as required by ECRI Institute or HRSA. Any detailed, fact-specific health center issues should be addressed to the FTCA helpline, and all questions regarding pending legal cases should be directed to your own organization's private attorneys. Now I'd like to introduce our speakers for today. Kathy Connolly joined ECRI Institute in July 2010 to provide national sales direction for ECRI Institute PSO, as well as input on development of patient safety and risk management consulting projects. She has over 20 years' experience in healthcare risk management, and as the principal with Premier Consulting Solutions, she led the National Perinatal Patient Safety Collaborative from 2007 to 2010 and a new Women's Services Line consulting team. Prior to that, she was the Assistant Vice President with Premier Insurance Management Services and was involved in patient safety and risk management projects with 112 healthcare facilities across the United States who are members of a risk retention group. As a registered nurse, she has worked in adult and neonatal intensive care units, labor and delivery, newborn nursery, and medical surgical units. Also with us today is Dr. Peter Sharoni. He is currently Emeritus Professor of Obstetrics, Gynecology, and Reproductive Sciences at the University of Vermont College of Medicine. He has strong clinical interests in obstetric healthcare quality improvement and is currently serving as the chair of the Institute for Healthcare Improvement, or IHI, Impact Perinatal Improvement Team. He was also the lead author of IHI's white paper, Idealized Design of Perinatal Care. In addition, he has been the chair of Quality Assurance and Improvement and Credentialing for the Women's Healthcare Service of Fletcher Allen Healthcare for the last 15 years. His recent research and work in obstetrics quality improvement is as chair of the March of Dimes Collaborative Improving Perinatal Care of Vermont and as co-investigator of the MedTeams project. Finally, we have with us today Chris Callahan. Chris is a registered nurse with a master's degree in business administration and has worked with ECRI Institute for more than 10 years. She has over 20 years' experience in health center daily operations for both primary care and specialty providers. Chris's past work experience includes as Assistant Director of Operations in a federally qualified health center in the New England area, and as Director of Ambulatory Nursing for a large managed care organization in Southern California, serving 100,000 members in 17 health centers. More recently, Chris works performing clinic assessments at both clinics and health centers, where she targets areas where staff can improve operational efficiency and clinical and risk management issues at the frontline level. With all that said, I will turn the program over to Kathy Connolly.
Thank you. Thank you, Paul. Welcome, everyone. As you can see on slide 3, we've listed the learning objectives for the presentation. I won't read through these, but you can refer back to them as you want. On slide 4, we see that almost 80% of obstetricians have been sued for professional negligence. This is according to results of the 2012 American Congress of Obstetricians and Gynecologists survey. They also go by the name ACOG. And this was their professional liability survey. The claims experience also begins early in an obstetrician's career. 42% of the respondents to this survey reported that at least one claim arising during their residency time period of their career. Obstetric cases are among the highest in damage awards of all specialties. Damages may be awarded for injuries sustained by the child, to the mother for any proven physical or emotional harm, and to fathers for emotional distress or relating to a derivative claim if married to the mother, as well as for economic losses. Providers in FTCA-deemed health centers, like their peers in other settings, are subject to a high rate of obstetric claims. Providers with a specialty in obstetrics and gynecology were named in more than 1/3 of the total incidents among FTCA-deemed health centers in fiscal year 2011. And obstetrics-related incidents resulted in the highest cost among all claims. So as you can see, taking steps to prevent errors in the obstetrics environment are important for not only protecting patient safety, but also for preventing high-dollar claims in FTCA-deemed health centers and other healthcare organizations. Moving on to slide 5, you see here, errors in labor and delivery are rarely due to a misjudgment or oversight on the part of a single provider. Instead, they typically result from multiple breakdowns or communication failures among the labor and delivery team. As we discussed throughout this presentation, ensuring effective communication among all members of the obstetric labor and delivery team is an important strategy for preventing adverse outcomes. Slide 6 lists some of the examples of what can go wrong during labor and delivery. In the interest of time, I won't read these cases, but you can go back to this slide and review them later. Moving to slide 7. However the problems may ultimately manifest themselves, we know that there are usually a lot of causes, some of them starting long before they affect individual patients. Do any of the contributing factors on this slide sound familiar? Complicating all these factors is the fact that in many health centers and free clinics, patient compliance with care may be less than ideal. For example, patients may not be seen in the health center until well into their pregnancy, may not come in regularly, or may fail to show up for appointments or tests. This fragmented or sporadic care can increase the potential for inaccuracy in establishing term due dates and make it difficult to determine when a patient is at 39 weeks gestation, the importance of which we'll discuss a little later. In addition, patient personnel or social concerns can increase the risk of poor outcomes. With any initiative to improve patient safety and quality of care, you'll need to start with your own organization and providers and analyze where any problems may be starting. Although issues related to noncompliant patients or patient social concerns is beyond the scope of this presentation, we'll discuss some strategies throughout this presentation that can help improve many of the problem areas listed on this slide, as well as additional problem areas you may be facing. You may also want to refer to the webinar and audio conference archive on the Clinical Risk Management Program website and view the previous audio conference on preventing missed or delayed diagnoses for more information. Starting on slide 8, we'll look at one of the situations that has a high risk of patient harm, which is the use of oxytocin for induction or augmentation of labor. Oxytocin, or Pitocin as it's referred to under its brand name, is one of the most commonly used drugs in labor and delivery. About 1/3 of all women receive oxytocin for induction or augmentation. Though oxytocin is generally safe, the medication has been associated with adverse maternal and neonatal events when contractions are sped up to the point that the fetus doesn't receive enough oxygen. The Institute for Safe Medication Practices considers oxytocin a high-alert medication because of the potential for serious overdoses, which can cause brain damage or death to the infant and may harm mothers who are hypersensitive to the drug. Oxytocin was also the #1 drug among the top 10 medications involved in wrong dose overdosage errors in the labor and delivery unit, as reported by the Pennsylvania Patient Safety Authority in its advisory on medication errors in labor and delivery. A guidance article based on this advisory is available on the Clinical Risk Management website. The standard of care permits a wide range of oxytocin doses and infusion rates, and there is a lack of evidence-based data on safe administration and dosing. Many malpractice cases against obstetricians allege misuse or overuse of oxytocin. Monitoring of the mother and fetus is critical when administering this medication. Oxytocin isn't the only drug used for induction of labor. Cervical ripening agents such as misoprostol and prostaglandin gel, which also carry risks, may be used, or other types of methods may be used. The labor and delivery team should ensure the use of safe processes for any drugs or methods used to induce or augment labor. The case study on slide 9 illustrates an unnecessary induction of labor and highlights some issues that we're going to talk about, such as informed consent and decision-making related to interpreting fetal heart rate patterns. An obstetrician suggested to soon-to-be parents that they induce labor at 39 weeks because the obstetrician was going out of town on vacation and most likely wouldn't be there to deliver the infant if natural labor occurred. The obstetrician told the parents that the infant was healthy and ready to be delivered. When the father asked about the risks, the obstetrician did not describe any significant risks. She allegedly did not inform the parents that induced labor increases the risk of tachycystole, failure to progress, and the need for a cesarean section. The parents chose to have the induction that afternoon. According to the parents' testimony at a later trial, they claimed the procedure was very aggressive, with high doses of misoprostol and oxytocin administered to the mother. The parents said that oxytocin was increased to extremely high doses despite tachycystole, and that when the fetal heart pattern became abnormal, oxytocin was further increased. As a result, the infant was born with hypoxic ischemic encephalopathy, cerebral palsy, and spastic quadriparesis. The child will require continuous care for life. The parents also claimed that the obstetrician was negligent in failing to timely respond to the need for a cesarean section because of a heavy workload. The obstetrician had delivered 5 babies in 19 hours, with 3 of those babies delivered by unscheduled cesarean sections. The parents sued the obstetrician and the hospital, and the case was settled for $5 million. The hospital also agreed to implement new policies for induction and augmentation of labor and a new requirement for informed consent. So you can see that there were a lot of factors that can contribute to an adverse outcome: a heavy workload, poor communication of risk to the patient, inappropriate use of medications, and many more. We're going to spend the rest of this audio conference talking about strategies to overcome these issues. But first, let's pause for our first polling question on slide 10, and I'll turn it back over to Paul Anderson. Paul?
Thanks, Kathy. And Tim, just giving you a heads up, this is our first polling question. For the folks who are listening, you'll see the question on slide 10, and we're asking whether your health center directly provides certain prenatal and postnatal services. So our answers, again, are on slide 10. If you provide pre- and postnatal care only, please press star 1. If you provide complete obstetrical care through labor and delivery, it'll be star 2. And if you do not provide direct pre- and postnatal care, it'll be star 3. And we all set to go?
Yes. For people that answered the question early, your answer may not have been calculated.
Okay. While folks are answering, I'll just remind everyone that we do include the results of the polling question in an upcoming issue of our Risk and Safety e-News. That's our biweekly e-News product. The next issue is this Friday, August 10th. If you're not on the list, if you don't receive that e-News regularly, please do get in touch with us. We'll get you on the list. We'll have the contact information near the end of the presentation today to go over that, but we do encourage that. Okay. Is polling closed?
No. If you have not registered your vote, I'll give you 3 seconds to do so.
Okay.
And the polling is closed.
Okay, great. And then, so thank you everybody for responding, and I will turn it back over to Kathy for the next slide.
Thanks, Paul. We're on slide 11 now. So now that we've stated the problem and potential adverse outcomes, what are some things we can do to help ensure safe and timely deliveries and the safety of both the mother and the infant? At this point, I'm going to turn the program over to Dr. Peter Sharoni.
Thank you, Kathy, and welcome, everyone. Thank you for participating today. To move on to slide 12, you can see a list of safe practices for induction of labor. And again, as you heard, there are associated problems with oxytocin and adverse outcomes. It's important to emphasize that they may not be all causative. Oxytocin may not be causative of these issues, but it's so frequently associated that it requires our attention, and indeed there are causative issues with oxytocin as well. These safe practices include the list you see, and we'll touch on each one of these in more detail. Whether it's assessing the patient, talking with the patient, and documenting that information, moving towards standardized process and procedures where appropriate, using documentation and fetal heart rate and uterine contractions, either electronically or manually, in a manner consistent with current NICHD guidelines, keeping effective communication, or how you do develop effective communication and teamwork among staff throughout your labor and delivery. And, of course, ensuring that a physician, if the initial provider on the floor is not able to perform a cesarean section, ensuring that one who is able to perform a cesarean section is readily available to a unit, that he or she has been contacted, and that information is documented in the chart to show that that occurred. So some of the common themes we'll touch on. Moving on to slide 13, of course, risk factors will depend on the individual patient and the clinical situation in which they find themselves. We don't have much trouble with the contraindications for labor induction, such things as placenta previa, prior classical cesarean section, umbilical cord prolapse, abnormal or transverse fetal lie. These are not really where the issues rise. We seem to be pretty comfortable across the board in these evaluations and know these contraindications. Of course, considerations for confirming gestational age from ACOG guidelines, which are well documented, initially thought about in the 70s because of the most common reason for admission to nursery ICUs in the 70s and early 80s was iatrogenic prematurity from elective cesarean sections and inductions, which were much less common then. But importantly, they devised the guidelines in 1988. They were re-upped, so to speak, in 2008, and in 2009 they were included in the induction of labor technical bulletin, so they're easily accessible. Confirming gestational age is important, and while it is quite integral to what we do in obstetrics, what we found at UVM and through some of the hospitals with the AIHI Perinatal Collaborative is that there wasn't a standard for documentation of gestational age. In fact, as we often say, if you want to know if you have a standardized process, just ask 5 people how they do it. If you get 5 different answers, you clearly do not have a standardized process. So the documentation of gestational age is not just writing in the chart, but it's also doing it correctly. You're either confirming menstrual dating if an ultrasound is eventually performed, but that infers that the menstrual dating was calculated appropriately, or you're establishing gestational age by ultrasound, and it's important that you comply with the guidelines regarding menstrual dating and confirmation and the range of errors so that your gestational age is indeed accurate. What you see on the bottom half of the slide is that we're looking for 39 weeks or greater in the setting of elective induction, which really, while we see the 39-week rule concept roll out, it's really confirmation of fetal maturity, not lung maturity, just confirmation of fetal maturity, which is actually the title of the guidelines from the American Congress of OB-GYN, or ACOG. Confirmation of fetal maturity, which includes 39 completed weeks with support of an ultrasound prior to 20 weeks if it's within 10 days, prior to 12, 13 weeks if it's within 7 days. Other clinical terms you can use is fetal heart tones is measured by, actually, we warned ACOG by saying Doppler ultrasonography. Some may think that putting an ultrasound on and seeing a heartbeat, but indeed that's not the case. This is using electronic Doptone. You need 30 weeks of documented fetal heart tones. And then finally, 36 weeks from positive serum or urine pregnancy test. This is important because they've become relatively user-independent at this point. They're easy to do and highly sensitive and specific. Moving on to slide 14, again, indications for induction of labor. You see a few of them here, 9 of them here, but that list goes on extremely long. And I use this as a caution for units not to get bogged down on what the indications for induction are, meaning medical or fetal indications, so that you get to the heart of the elective induction issue. If you continue to try to make a list of indications for induction, you'll never get to the important point, which is limiting elective induction prior to confirmation of fetal maturity, or as we said, 39 weeks. Ultimately, there's a judgment on whether the benefits of inducing labor outweigh the risk of continuing the pregnancy. Of course, documentation should always be within the chart regarding the rationale for any decisions. Contemporaneous documentation is extremely important in the setting of A, legal review, B, a decision to potentially litigate, and finally during the litigation itself. On slide 15, you can see the discussion of the risks of early elective delivery, and they're essentially just extensions of preterm delivery, what neonates suffer at the hands of their early delivery in the setting of preterm delivery. And these are all the risks, including induction, which has an overall higher rate of cesarean delivery. While these risks at 37 or 38 weeks may be relatively small compared to 39 weeks, the data we've seen in the last 3 to 4 years has clearly documented that there is a higher risk at 38 weeks, about 1.5 to 2 times, of things like RDS and ventilator usage. At 37 weeks is 2 to 4-fold higher than 39 weeks. So all the numbers are relatively small, but clearly and persistently, 37, 38 weeks neonates are different from 39 weeks, and certainly in the elective setting, you want to confirm fetal maturity to minimize these risks. Despite the well-known risk of these early deliveries, we continue to see elective deliveries before 39 completed weeks, and in fact, when this all began, it was up to 1/3 of all elective deliveries. And again, referring to early deliveries that do not have a medical or fetal indication. There are multiple social, if you will, indications for induction, and they should generally be considered elective. In some cases, a patient may have a medical complication, and the benefits of moving toward delivery is clearly going to outweigh the risks of continuing the pregnancy. Moving on to slide 16. There's multiple data tools out there now, both from CMS and the Centers for Disease Control, CDC. From 1990 to 2006, the rate of induction about doubled. And more recent data from 2009 showed actually a drop in the rate of overall preterm births in that same time period. However, late preterm births in the 34 to 37 week, 34 to 36 and 6-day week range have continued to move up over time, while early preterm labors under 32 to 34 weeks have remained stable over the same 20 to 25-year period. So the increase in late preterm has really been responsible for the rise of preterm birth over the last 25 years, even though there has been some stability recently. Although we don't know with this data how many of those patients were induced and some of the preterm births which may have been medically indicated and how many were versus elective, still a high rate of preterm births is concerning by multiple regional, state, and national groups. And one reason for the overall declining rates may be the recent educational efforts since about 2004-2005, especially to eliminate elective deliveries prior to 39 weeks. In fact, hospitals within the IHI Collaborative have shown a significant improvement in delivery in these aspects, in these gestational age ranges, 37 to 39 weeks, with elimination in some hospitals. On slide 39, we see early and full-term births from 1990 to 2009, some of the data we were just talking about. And indeed, if you look at the left at the blue-green bar, you can see from 37 to 38 to 39 and 40 weeks at 1990, where about 37% of deliveries occurred at 40 or 41 weeks. You can see a significant drop-off as we jump up 15, 16 years in 2006, 7, 8, 9, which are the four right bars, where things have remained relatively stable. There has been somewhat of a drop-off in the 37 to 38-week age group, as you can see from the left group. And that's important because, again, the educational efforts around essentially elimination of elective deliveries prior to confirmation of fetal maturity, which is 39 weeks by most clinical criteria, that education began in the mid part of the last decade, about 2005. It appears to have been effective, and you saw the similar increase in the 39-week group. Moving on to slide 18, Stephen Clark published in the Gray Journal in late 2010 and looked at three different approaches of process improvement to eliminate elective deliveries in their large healthcare system. The three were a hard stop, a soft stop, and the third is an educational approach with providers. Let's touch on them in a little more detail. What a hard stop is, essentially, what's happening is on labor and delivery, a provider is not able to schedule an induction or a cesarean section without a medical indication prior to 39 weeks. This needs to go through an immediate prospective review process prior to potential scheduling or delaying that schedule. On the soft stop approach, it's similar, but when that's implemented, the decisions to deliver are left up to the individual clinician, although such cases are reviewed retrospectively by local peer review committee and education occurs. So importantly, in the soft stop approach, you have retrospective review. It's relatively clear we need to move more aggressively toward prospective quality control, and that's what the hard stop allows. The third approach is educational tools for providers on the importance of eliminating these deliveries. And as a group, all three together, they saw a drop of about 55% in elective deliveries prior to 39 completed weeks. It was higher in the hard stop approach, not surprisingly, and that was recommended as the primary approach if that's doable in a given labor and delivery unit. In addition, neonatal intensive care unit NICU admissions declined by 16% over the same time period. So clearly the elective late-term group from 37-0 to 38 and 6 did represent a NICU group who were going to the NICU unexpectedly, although in relatively low numbers, they were still doing that, and the hard stop policy was most effective in eliminating this, followed by the soft stop, and then finally the educational aspect. So there are tools out there and policies you can implement to reduce this that are already active and already in the literature. Slide 19, any approach, of course, to eliminating early elective deliveries has to keep in mind that there will be cases where it's not clear, and that's where I get back to trying to make a list of what the appropriate indications are. That becomes difficult. We try to consistently teach to just focus on the elective ones, the purely elective ones, and get your systems down. Although look at your indications over time and then start to discuss indications within the unit to see which are appropriate, maybe which are a little softer. There is ample documentation literature around many of them. For instance, macrosomia is not considered an indicated induction. There's ample data in the literature that supports an induction in the setting of macrosomia only increases the risk of cesarean delivery. So we do have data that supports individual indications and others that can help drive some of the discussion and decision. But importantly, where there is indications, those cases, clinical judgment should be used, and a discussion with the patient around the benefits and the risks of delivery is important. Patient consent is important, and documentation of that consent is important. Moving on to slide 20, you can see a couple of the current initiatives around CMS, Centers for Medicaid and Medicare Services, and the March of Dimes to eliminate these deliveries. You should also know that things like that groups like JCO have been collecting this information for a year or two now. In states like Texas actually passed a law that they're not going to even pay for risks associated with elective deliveries prior to 39 weeks. Although there had some political maneuvering and backing off on some of those issues, a number of states are looking at that. As money gets tight, they're beginning to consider whether or not these are never events, whether elective deliveries should ever occur prior to 39 weeks. Certainly a reasonable question, but at least it pauses us to think about it. So whether it's March of Dimes or CMS, there's tools out there to help obstetric providers as well as the facilities implement these policies or practices. As Steve Clark data has shown, there are straight, well-defined policies to help the practice of helping eliminate early elective deliveries. Moving on to slide 21, besides adequately assessing patients and avoiding purely elective deliveries in this setting, there's multiple other risk reduction steps that you all can take individually and as well as on your unit. Regarding discussing these processes and risks with patients, nothing's better than contemporaneous documentation in a chart about informed consent. Again, you're not trying to document everything you state word for word, but sometimes just a single line that says risks and benefits discussed and reviewed with the patient understands and wishes to proceed with current plan. It takes about a line, takes a moment to write that, and it really assures the documentation. The problem with an informed consent actually sheet that the patient signs is because it's very difficult to go over everything, and if it isn't separately documented in the chart, we not uncommonly see in litigation that the informed consent is thrown after the patient said, she signed it, but it was never reviewed with her in detail, et cetera, et cetera. So in a litigation setting, we want to have adequate contemporaneous documentation of the discussion actually happened. If oxytocin or other medications to induce or augment labor will be used, same thing should happen. The risks of the medication should be adequately explained. One strategy of teaching back allows the patient to bring the information back to you, whether it's patient or family or all together, so that they verbalize this information. The general problem with that is most of the documentation in the literature would suggest that during informed consent processes, even in research settings, patients only retain about 10 to 20% of the information. So, as I stated earlier, while saying the patient understood, I don't say appears to understood. I say the patient understood or understands, because that's an impression of the clinical provider, and you're certainly able to say that. So the process generally involves explaining that concept, providing that information when you're teaching back, and asking the recipient to explain what they recall. And in reality, you continue to repeat the cycle until you're comfortable that the patient understands the information. For some other communication tips and techniques, including communication tools, there's multiple standardized communication tools for providers out there like SBAR or AskMe3. Feel free to review the audio conference, Clinical Risk Management Basics, Part 2, which is archived on the Clinical Risk Management Program website. Not surprisingly, as I mentioned multiple times, all discussions with the patient and the patient's informed consent needs to be documented in the patient's record. Moving on to slide 22. Verdicts show that both plaintiff's claims regarding informed consent as well as other issues that they clearly resonate with juries. And why? Because juries are generally lay individuals without medical information, and they get confused with the information that's presented at trial. There's 8 principles highlighted in ACOG's 2009 committee opinion on informed consent. It clearly is an ethical issue. By performing it well, it does express respect for the patient's right for medical decision-making and being involved in the medical decision-making. Communication, of course, is bedrock to informed consent as well as good patient and quality care. And it establishes an environment and a relationship with the healthcare providers. And in that environment, it's fostered and facilitated patient involvement. Informed consent is ultimately an information sharing process that occurs over time, so it doesn't have to be just the signature at the time of that form. That multiple documentations in the outpatient area, in labor and delivery, at the time of implementing whatever process it is going to drive home that point, if it goes to litigation, that you tried every effort, or you did every effort to convince yourselves and the patient that the information exchanged hands. And of course, it incorporates ethics and ethical principles, as well as it complies with state and federal requirements, as well as your institutional policy. Patient-centered care and overall shared decision-making are important concepts in obstetrics care, not surprisingly, mainly because this is how you get to the shared value and culture and choices and preferences of the patient. Important to note that patients rarely, if ever, have positive rights to make you do something you think is against their best care, but they do have negative rights. They can decline any of the care that we recommend for them. When you're inducing labor, of course, risks and benefits of oxytocin, as well as the induction itself, need to be reviewed with the patient, as well as documented. And again, the patient should be encouraged to ask questions so that you perceive an understanding. Of course, this should be in the patient's primary language, and if this isn't possible, you need to use interpreters to be available to translate the form into the patient's primary language. Again, an important aspect that shows what we're trying to do is appropriately convey information to the patient and communicate appropriately the information we're trying to get to them. Slide 23. Having standardized processes and procedures also lead to improvement in obstetric outcome. Importantly, you standardize what can be standardized. There's many things that cannot be standardized. For instance, I can't say how to standardize a process of management of a Category 2 fetal heartbeat tracing because there's too many clinical variabilities. So you standardize what's standardizable. Examples of successfully uniform processes for obstetric care you can see on slide 23. For the practices of OB, process standardization helps to ensure that all providers on your team know what everyone else is thinking, because there's a standardized process that goes from, say, A to G, and everyone knows what the next step is supposed to be, and they know what the other team's roles are. Safety science, which there is abundant reliability in safety science out there, tells us while there's always process variation, which reduces quality, process standardization leads to improved quality if you standardize something that can be standardized. And many, many things of what we do within our processes can be standardized. Therefore, one of the standard ones is clinical administration of oxytocin. That places patients at increased risk. Oxytocin is a high alert medication, so increased risk for adverse outcomes, and providers are at increased risk, therefore, for litigation. It does lend itself to the process of standardization. The perinatal care bundles, which we see on slide 24, are an important concept around standardization. Checklists are also standardization. The difference between checklists and care bundles, as defined through the Institute of Healthcare Improvement of IHI, bundles are a group of individual issues that should occur for every patient every time a given process occurs. So you see 4 things listed for an elective induction bundle and 4 things listed for an augmentation bundle. If you do 3 of those things, you don't get a 75% in your measurement of bundle compliance. You get a 0. It's important that you're looking at how often you do all 4 of those agreed upon things for each patient, whether they're getting an elective induction bundle or an augmentation bundle. So bundle compliance is a much sensitive assessor of your process, and that's why they were developed. This all-of-none feature is the source of the bundle's power. And these are 2 typical bundles that were implemented within the perinatal project. There are many outside the perinatal project as well. And Kathy will mention the vacuum delivery bundle, which has also been developed through the perinatal group of IHI. Moving on to slide 25. To guarantee all elements of the bundle are dependably addressed, and to ensure the safest use of oxytocin, the use of standardized order sets are quite helpful. There are multiple Pitocin protocols out there that all have very little variation, and you have to ask yourselves whether you want multiple oxytocin protocols on your labor and delivery unit if they really don't have any clinical benefit. if you can narrow that down to one protocol being used the majority of time and augmentation or induction occurs, you're making it much safer for the end user, which is generally the obstetric nurse, that you standardize the process, that everybody knows what's supposed to happen. Checklists, on the other hand, fill-in blanks can also be used. These checklists and forms are meant to serve as forcing functions and reminding functions, a redundancy built into the system. And when we think it slaps at our professionalism by using something like this, I remind myself as well as others that pilots have a checklist which includes putting the wheels down. Something as functional to them and as basic to them as putting the wheels down. They don't have to use it that often. They check it off, but on occasion, and actually within the last few months, there was a distracted group within the cockpit who almost forgot to put the wheels down. So we can all forget fundamental processes to our profession at times, and it's nice to have those redundancies in place, especially for very important processes that cannot be overlooked. You make it easy to do the right thing because the checklist is in front of you or the bundle or whatever it might be. And some examples of these checklists, particularly for oxytocin use and induction, you can see on the slide, as well as under the ACOG group, particularly related to oxytocin for induction and the protocols of those as well. On slide 26, we can see a standardized sample for protocol for oxytocin, depending on which one you decide to use, what your initial dose is, what the infusion rate is going to be per hour, what the incremental increase will be. I can tell you that many hospitals have moved to 30 units of Pitocin in 500 cc's of their dilutant, often half normal saline. And while that sounds odd, 30 and 500, it actually comes down to 1 cc an hour equals 1 milliunit per minute. So a 1-to-1 ratio on your controlled infusers is a little nicer than a number of hospitals have found is nicer than trying to calculate multiple tables of 3 or 6 or whatever you might be using. Of course, deciding on a maximum dose should be driven by guidelines, and high-dose protocols do go up to 42 milliunits per hour. And a number of hospitals have chosen one high-dose and one low-dose protocol. But at least that's better than having 15 different protocols out there, as you can see. Plus, when you have complications related to oxytocin and you have multiple protocols, it's really hard to nail down where the problem may have arisen. If you only have 1 or 2 protocols, it's generally pretty straightforward to fall back where the issue occurred and then correct your process and move forward. Moving on to slide 27. Documenting fetal heart rate and uterine contractions. A lot of this comes down to agreeing on definitions, specifically driven through the NICHD 2008 guidelines. Attending physicians, residents, all OB providers who administer oxytocin or who are on labor and delivery are responsible for monitoring patients during labor and delivery should be familiar with and trained on the effects of the drug. We use Pitocin quite often, as low as 30% of the time, but most average units, their intrapartum patients see it 50 to 55% of the time. It's understandable when people in the lay public don't understand why we don't know everything about this medication and completely understand it, because we do use it very frequently, if not all the time. We should know everything about it. We should also know how to monitor appropriately in the setting of oxytocin use. When a patient is placed on oxytocin intrapartum, she becomes a high-risk patient in the sense of monitoring. So she needs to be monitored accordingly with continuous monitoring or every 15 minutes in the first stage, every 5 minutes in the second stage for intermittent auscultation or monitoring. So it's important that we follow those protocols. It's also important we agree on nomenclature and standardized terms and that individuals and personnel are trained in those terms. We're not talking the same language. We're not using the same definitions. We're not talking the same language. Communication errors occur. Some common contributing factors within claims as well include fetal assessment or fetal heart rate monitoring, specifically in the presence of oxytocin. You do not want to see oxytocin increased in the presence of Category 2 or Category 3 tracing or previously non-reassuring fetal assessment without a reasonable discussion taking place with the entire obstetric team caring for the patient. if being on the committee and the group that wrote the NICHD 2008 guidelines, the whole goal of categorizing the tracing, particularly the Category 2 tracing, which is an abundant percent of what we deal with. The goal is to get everybody at the bedside and make a decision on where to go with that patient, and that's the goal. Category 2 is unclear. You need to have ongoing decision-making. You need to have everybody at the bedside helping to make that decision acutely. Because fetal heart rate tracings are likely to play an important role in obstetric lawsuits, it is important that all health centers, clinics, labor and delivery facilities, whether it's an antepartum test or an intrapartum monitoring, that this documentation is available and retained appropriately. That's 21 years here in Vermont. At this point, let me go ahead and turn it back over to Kathy as she'll move forward to the rest of the slides. Kathy.
Thank you. Slide 28 summarizes communication and information flow, the effectiveness of which is key to improving obstetrical safety and reducing the risk of liability. Communication breakdowns within the healthcare team can result in delayed decision-making to the detriment of maternal or fetal well-being. Some specific risk areas include a lack of communication between covering providers and the attending obstetrician, and a breakdown in communication at shift change or handoffs in patient care during a shift. In the health center or clinic settings, protocols should be put in place so there is a consistent delivery of care across all providers and across all types of clinical problems. It is important to proactively identify areas of discord and gain consensus as to how the practice will handle a particular medical concern or situation. Be sure that there are clear ways in which providers are to communicate with each other, especially during off hours. Communicate clearly that all administrative delays, such as a lack of availability of a timely diagnostic test, faulty equipment, or insurance delays for pre-authorization or pre-certification, should be brought to the attention of the practice management team. This is to avoid unnecessary delays in patient treatment. Covering providers need some process to gain an understanding of the patient's history, status, and any aspects that may place the patient at increased risk of problems. Whenever possible, ensure that patients rotate through your health center and see all providers that could be involved in their delivery. Being the attending obstetrical provider who meets a patient with a complicated obstetrical history and numerous health issues on the day she is admitted to labor and delivery is very risky. If a different team of providers will be delivering the patient, clinical risk management demands a fail-safe means of communicating patient information among prenatal, labor and delivery, and postnatal providers. It is important to develop a mechanism to ensure that OB records are transported to the hospital or birth center by the 36th week of gestation. In addition, after 36 weeks, make sure that any documentation from patient visits are faxed or sent to the delivering facility on a weekly basis. Prenatal care is an intensive 8-month period of care for two connected but distinct patients during a time of marked physiologic changes for both, with the potential for adverse outcomes that can lead to fatal or lifelong consequences. Prenatal care also inevitably leads to care by many providers at several locations, such as offices or clinics, hospitals, birth centers, or emergency rooms. Almost nowhere else in medicine is the availability of an outpatient medical record as essential as it is with pregnant patients, and it is equally important that the information at hand is current. Review your systems at all levels, from the office staff who are scanning any necessary diagnostic testing to the medical records clerk responsible for sending information to the delivering facility, to the unit clerk in the labor and delivery unit who is responsible for receiving the information, to ensure that all necessary prenatal information and diagnostic testing is available to the provider and labor and delivery team. There's various resources in the clinical risk management program that address the communication topic as well. On slide 29, during labor and delivery, all staff members who are involved in the care of the mother and infant should be considered integral members of the team. All labor and delivery staff should know their roles and the roles of other team members and should be empowered to speak up anytime they recognize an error or a threat to the patient's safety. Conducting teamwork training and simulated drills of obstetrical emergencies can help ensure that all team members are prepared for various types of situations that can occur during labor and delivery, and they'll thus respond quickly based on their training from the drills. On slide 30, when inducing labor, a clinician who has privileges for performing cesarean deliveries should be aware of the induction and should be readily available. The availability of the clinician and the response time in cases in which the clinician is needed to perform a cesarean delivery should be documented in the medical record. The case study on slide 31 highlights what can happen when there are breakdowns in communication among labor and delivery staff. In this case, the patient was post-term when she presented to the hospital for a scheduled induction of labor. The attending obstetrician noted the presence of meconium after he broke the amniotic sac. The patient developed an elevated temperature and electronic fetal monitoring tracings showed significant late decelerations. When the attending obstetrician went off shift, another team took over the patient's care. A covering physician examined the mother at 5 a.m. and suspected choriamnitis. He prescribed antibiotics and allowed the labor to progress. As the labor progressed, fetal heart rate tracings showed both late and variable decelerations and a loss of beat-to-beat variability, indicating that the fetus was becoming acidotic as a response to oxygen deprivation. Excuse me. The attending obstetrician resumed his shift at 7:30 a.m., but did not call for an emergency cesarean section until 1 p.m. Fetal heart rate tracings taken at 1:20 p.m. showed a prolonged severe deceleration from which the infant did not recover. The infant was delivered by cesarean section at approximately 1:35 p.m. with a tight nuchal cord wrapped around his neck and no heart rate, respirations, muscle tone, or muscle reflex. He was resuscitated but will require 24-hour care for the rest of his life. This case went to trial, and at trial, the attending obstetrician admitted liability for deviating from accepted standards of care. But he also reportedly attempted to shift responsibility to the team who managed the shift when he was off duty, because he testified that the indications for performing an emergency cesarean section were present at least 2.5 hours before he resumed care of the patient, and that the physicians who were managing the patient at the time did not advise the attending obstetrician of the need for an emergency cesarean section when he arrived at the hospital to start his shift. The judge in the case found all the defendants liable for negligence, and he concluded that the attending obstetrician unreasonably relied on the team that covered for him after he left his shift. In light of the patient's condition, it was the attending obstetrician's obligation to contact the staff who would cover for him on the next shift to inform them of the patient's clinical condition and to instruct them to summon him if the patient's clinical situation appeared to be deteriorating. The verdict in this case was more than $60 million. We'll move on to a brief discussion of the risks related to operative vaginal deliveries, also known as instrument-assisted deliveries, on slide 32. According to a recent data brief issued by the Agency for Healthcare Research and Quality, from 2000 to 2009, the rate of obstetric trauma decreased in both instrument-assisted deliveries and deliveries in which instruments were not used. However, as you can see in the graphs on this slide, the rates of obstetric trauma decreased more rapidly in deliveries in which instruments were not used. Overall, the rate of obstetric trauma was higher in instrument-assisted deliveries during the 10-year period than in those without instrumentation. In fact, the rate of obstetric trauma in instrument-assisted deliveries was more than 6 times the rate in deliveries without instrumentation in 2009. Slide 33 lists the Institute for Healthcare Improvement's vacuum delivery bundle. Like gun bundles we've discussed earlier, this was implemented through a collaborative with Premier Ascension Health and the Institute for Healthcare Improvement. It begins with requiring that consideration be given to other delivery alternatives. Serious complication of vacuum devices occur in approximately 5% of vacuum attempts. Patients need to be aware of these risks, and informed consent should be obtained and documented. Because trauma associated with operative vaginal deliveries is varied, forceps and vacuum extractors must be used according to ACOG guidelines. Operative vaginal delivery becomes a high-risk procedure when there is a low chance of success, when the provider uses a trial of operative vacuum delivery, when the provider uses a combination procedure with forceps, and when the gestational age is less than 34 weeks. According to experts writing in the literature for a safe vacuum-assisted vaginal delivery, the most important thing is to obtain a proper application. Estimated fetal weight is critical to the procedural risks, and station and position of the fetus must be known. Because cephalohematoma is directly correlated with application time and multiple pop-offs are associated with cephalopelvic disproportion, fetal injury, and failed procedure, these aspects of the procedure should be predetermined by protocols. In the case of a failed vacuum delivery attempt, alternative delivery options and a resuscitation team should be readily available. Slide 34 lists a protocol for instrumented or operative vaginal deliveries. This protocol was implemented by Ascension Health's National Perinatal Safety Program after implementing systems over a 3-year period to ensure that evidence-based practices were reliably followed for high-risk conditions associated with perinatal harm, that robust strategies for communication were adopted, and that collaborative practice was promoted among caregivers participating at their various facilities and hospitals. They achieved a birth trauma rate that were at or near zero. The participating facilities also saw a reduction in the use of vacuum or forceps from a frequency of 7.4% to 4.1%. Slide 35 lists risk reduction strategies specifically for vacuum-assisted delivery. Residency training should be supplemented with formal mentoring programs, and proper credentialing and privileging of providers is a must. Policies that specify parameters such as indications and contraindications for vacuum-assisted delivery, total time of procedure, maximum time and pressure of vacuum use, and maximum number of pop-offs should be implemented. Practice of teamwork drills should be drills to refine effective communication of these parameters should also be routinely carried out. Consider bundling vacuum-assisted delivery into a set of criteria, all of which must be met in order to proceed with the procedure. Standardized documentation of vacuum-assisted vaginal deliveries. And implement audits of the obstetrical care unit as well as individual obstetrical providers. Know the rates of vacuum-assisted delivery, vacuum-assisted delivery failure, sequential device use, neonatal morbidity to composite trauma, APGAR score of less than 7 at 5 minutes, and cord arterial blood pH of less than 7.1, or other facility-specific parameters and measures you may be monitoring. Moving on to documentation concerns on slide 36. The legal defense of a medically defensible case can be significantly hampered by the lack of documentation or loss of records that are key to the plaintiff's case, such as electronic fetal heart rate tracings, progress notes related to the delivery, nursing flow sheets, nursing notes, and blood gas test results, or the loss of clinical specimens, for example, the placenta and radiology studies. Creating and maintaining accurate, clear, and concise documentation that provides the rationale for the obstetrician's judgment and actions, and placing a litigation hold on relevant records and documents can reduce the risk of unwarranted lawsuits, thwart claims of spoliation of evidence, and bolster the obstetrician's credibility when testifying about events that may have happened years ago, an important consideration in light of the long statute of limitations that exists in some states. Common factual scenarios that are seen in cases alleging failure to timely respond to fetal distress include the obstetrician's absence from the hospital during labor, lack of documented communication between nurses and obstetricians concerning interpretation of fetal heart monitor strips, and delay in responding to changes. Thus, a failure to perform a cesarean section with 30 minutes of making the decision to do so may be alleged. Slide 37 addresses what information should be documented for operative vaginal deliveries. You can also find more information on operative vaginal deliveries and vacuum assisted on the Clinical Risk Management website. We'll conclude on slide 38 with an example of one health system's initiative that resulted in improvements in obstetric safety. I'm not going to go through the 5 principles that are listed there, but this describes the actions taken at Nashville, Tennessee, at the FTCA, Hospital Corporation of America system, where they did a whole program on trying to improve patient safety and focused on process improvements for obstetric care. You see the 5 areas that they focused on and trying to make improvements. As a result of working in these 5 areas, the organization's efforts resulted in improved perinatal outcomes, reduced rate of cesarean section, lower rates of maternal and fetal injury, a 50% reduction in the number of claims, and a 5-fold reduction in cost of claims. And now I'll turn it back over to Paul for our last polling question.
Hey, great. Thanks, Kathy. And Tim, just giving you a heads up, this is our second polling question. To our audience, you'll find it on slide number 39. And on this polling question, we're simply asking how many folks are in the room with you listening to our presentation. So once Tim gives you the go-ahead, simply press star and then the number on your keypad that corresponds to how many folks are in the room. So if there's 1 person there, star 1, 2 people, star 2, and so on. If there's 9 or more, please press star 9.
Okay, and you may begin.
Okay. While you're responding, I'll just let everyone know that once we conclude the polling here, we'll wrap up. We'll go into our Q&A program. So if you do have a question for any of our speakers today, please know that we're just about ready for you, and we'll do that as soon as we wrap up the polling here.
And again, if you have not logged your response, please do so. Three more seconds.
Okay.
Okay.
All right. Thanks, Tim. Just before we move to the Q&A, I'll let everyone know that their final 3 slides in the slide handouts, numbers 40, 41, and 42, do include all the references and citations that are included on the slides today. So I do encourage you to refer to those if you need some more information or some of the background on some of the information that was presented. And with that, we'll open up the Q&A.
And again, if you would like to ask a question, please make sure your phone is unmuted and press star 1. When prompted, record your name slowly and clearly. Once again, it's star 1 if you have a question. One moment, please.
Okay, and while the questions are queuing up, I'll just direct everyone to the very final slide in your packets, number 43, and that includes all our contact information. If you have a question that we don't get to on the Q&A, if you'd like more information about any of the resources that we talked about being part of the Clinical Risk Management website, if you need access to the website or to get on our mailing list, I'll read them one time and encourage you again to look at that last slide. You can give us a call at area code 610-825-6000. Our extension is 5200. You can also give us an email at clinical_rm_program@ecri.org. That's clinical_rm_program@ecri.org. Do you have any questions in the queue?
No, we have no questions in queue.
Okay, we'll give it just a moment to see if anybody does want to jump in. And again, if you do have a question, but for whatever reason don't feel comfortable sharing it to the larger group, we certainly do welcome your questions to come into us at any time through either our email hotline or our voicemail hotline, and we'll certainly get those in the hands of our speakers and our other experts we have available to us here at ECRI Institute, and we'll get you a response. Anybody queued up, Tim?
No questions in queue.
All right. Well, I think in the interest of time, we have run a little bit long here, so I'll say to everyone, thank you very much for attending. To our speakers, thank you very much for your time and sharing your insights with us. I think we'll call it a day here, and again, so to our audience, please do feel free to shoot us an email, give us a phone call at any time if we can provide some additional guidance.
And today's call has ended. Please disconnect at this time.